Okay, my voice clear or not? Okay, I have a few cases to share with you all. Um, I thought I just present two cases, but it's end up with four cases. I thought I will present short and sweet presentation, but it turns out to be 70 something slides. So sorry, but I tried to make it fast. Okay. Okay, first case, 72-year-old male, known case of CVA, diabetes, hypertension, admitted to HSP for pneumonia. He have left hemiparesis since 2014, but able to ambulate with help. Was diagnosed having multinodular goiter for 10 years, but euthyroid, but recently have hoarseness of voice and rapidly increasing in size. So FNA was proceeded in September 2019. And on examination, patient was cachexic, pale, lethargic, slurred speech, right facial palsy, anterior neck swelling, 8 times 5 cm, heart irregular, fixed to underlying structure. Laryngoscope was done. It shows right vocal cord palsy. Okay. Okay, this is the FNA finding. The smears quite cellular. Background, a lot of background necrosis. There are aggregates of cells, loose, and some in single cells. Okay, on higher magnification, I think you all know the diagnosis already. This is a straightforward case, just for introduction. Okay, you can see there are a lot of large cells with very big pleomorphic nuclei, and I think this is mitosis, abnormal mitosis. Okay, there are also single cells, looks plasmacytoid. Some are multinucleated, binucleated. Okay, this is on higher magnification. Some looks rhabdoid. Okay, in other areas it shows prominent vessels and large cells. Okay, the nucleus looks very horrible, like a monster. Okay, and this is a prominent vessels with big cells, prominent nucleolus. Okay, this is a cell block. It shows the abnormal cells, some with intranuclear inclusion, with very prominent nucleolus, and background necrosis. So of course the diagnosis is anaplastic carcinoma. Unfortunately, patient passed away September last year. So just a little bit about anaplastic carcinoma. It's extremely aggressive, less than 5% of malignant thyroid tumor, rarely seen in patient in less than 50 years old, usually female preponderance. Patient presented with hard nodular neck mass, infiltrates into surrounding extrathyroidal structures, and usually has an obstructive symptom. Usually, patient has history of long-standing goiter, like this patient. Immunohistochemistry, pan-CK and vimentin can be positive. However, TTF and thyroglobulin usually negative. So by the time they are diagnosed beyond the thyroid, the tumor is already beyond the thyroid and it becomes inoperable. Surgery is only palliative and radiotherapy is only for control the local disease. So this is the cytomorphology description that I mentioned before. Differential diagnosis of anaplastic carcinoma, if we have very little cells, it can mimic atypia of cis lining cells. I think Dr. Mukarama has shown us before. And also medullary thyroid CA, sarcoma, but sarcoma is very rare in thyroid, metastatic carcinoma, and treatment effect, radioactive iodine, and also medical treatment. Okay, next to second case. This is a little bit difficult. 24-year-old female, 1-year history of right neck swelling, progressively slowly increasing in size, has no other symptom. Ultrasound shows irregular, heterogeneous, hypoechoic solid lesion in the right lobe, measuring 2.6 in widest diameter. Proceeded with FNA. So this is the FNA smears. Oh, okay. I should speak louder. All right, sorry. Okay, this is the smears. It's low to moderate cellularity, a lot of blood in the background. Okay, there are some clusters and sheets of cells obscured by the red blood cells. Okay, this is on higher magnification view. There are sheets and clusters of cells. We can appreciate some nuclear overlapping. It doesn't look like typical goiter features. Okay, but there and also there's a lot of blood in the background, most likely because of the fixation artifact. Okay, due to blood. Okay, this is pap smear. Okay, we can see more clearly the cells. There are nuclear overlapping here. And sometimes maybe we can see a little bit like a vague papillary formation here. But at the same time, we can see microfollicle formation. Okay, here. Okay, on higher magnification, there's a microfollicle pattern. Okay. And if you can focus to the nucleus, okay, the chromatins looks a little bit powdery. I mean, a slight prominent coarse chromatin. Maybe some grooving. Okay. Okay, on higher magnification, this is GIMSA. Grooving. Okay, grooving. You can see grooving here, but not extensively grooving. Okay. Maybe it's intranuclear pseudo inclusion. Here. Grooving here. Actually, this case is quite difficult to diagnose. Here also grooving. Here, this one, and the nucleus looks elongated, oval shape, and some have angulated border. Okay. Maybe some pseudo inclusion here, and microfollicle pattern here. Okay, another. So, because of the cytological diagnosis, they proceed with right hemithyroidectomy in July 2019. So the finding on gross specimen, in the right lobe, there are 2 separate encapsulated solid nodules, one in the lower pole, measuring about 23 times 22 times 20 mm, and another smaller nodule in the upper pole, okay, which is 4 mm in diameter. The cytology diagnosis is suspicious of PTC because of the nuclear features, even though the papillary structures is not so obvious. Okay, so this is the thyroid nodule that seen in the gross specimen. Okay, this is the nodules, and this is the normal thyroid parenchyma. The nodule has a thick capsule, very well defined, and the tumor looks predominantly in the microfollicle pattern. Some are macrofollicles. In other area, okay, as we can see, this is the tip capsule, but this area it shows there is a capsular invasion. It goes beyond the capsule. So this area shows capsular invasion. Okay, in other areas, another clusters of cells beyond the capsules. So this nodule shows capsular invasion. Okay, on higher magnification, okay, this is how the cells looks like. Okay, it's tally with the cytological finding because, all right, see the arrow here. This is inclusion, grooving. Okay, grooving, clearing. I think this is another inclusion. Clearing, nuclear clearing, or often any eyes. Okay, another grooving. And the nuclear membranes is some are irregular. Okay, and sometimes chromatin denser at the margin. Okay, this is another grooving. So these features, it's like nuclear features of the papillary carcinoma. However, no papillary structures. Okay, this is the smaller nodule at the upper pole. Also shows very thick capsule. However, no capsular invasion. But the nuclear features is also the same with the larger nodules. It shows grooving, clearing, okay, nuclear irregularity, and inclusion, I think, somewhere. So because of the findings, the diagnosis is NIF-TP for the smaller nodules, and the larger nodules shows invasion, capsular invasion. The diagnosis is probably invasive encapsulated follicular variant of PTC. Okay, so I will talk a bit of NIF-TP later. Okay, so this patient, completion of thyroidectomy was done later, and patient still under close follow-up as well. And CT scan latest noted there is small nodule in the lung, so far under investigation and follow-up because it's too small to get the biopsy. So a little bit about NIF-TP. NIF-TP is non-invasive follicular tumor with papillary-like nuclear features. Okay, formerly known, this is non-invasive encapsulated follicular variant PTC. It is encapsulated or circumscribed neoplasm with follicular growth pattern and nuclear features of PTC. The diagnosis of NIF-TP requires surgical excision specimen because to diagnose NIF-TP, we need resection, not based on cytology. Okay, because we cannot exclude the capsular invasion. Most commonly associated with molecular alteration, RAS. Okay, indolent. It is indolent disease with excellent long-term survival. NIF-TP is considered a borderline RAS lineage tumor between follicular adenoma, follicular carcinoma, or invasive EFV PTC. So I think Dr. Mukarama has already mentioned regarding the diagnostic criteria for NIF-TP. So this is the inclusion criteria with major and minor features. Okay, the major features, encapsulation, follicular growth pattern must be less than 1% papilla. Okay, this is only for resection specimen, not cyto. So if solid trabecular insular pattern seen, it should be less than 30% of total tumor. No psammoma body, and the nuclear features of the PTC that I was mentioned just now must be included. So there is scoring for the nuclear features. And then for minor features include dark colloid, irregular shaped follicle, sprinkling sign, follicles cleft from stroma, multinucleated giant cells within follicles also can be seen. Okay, exclusion criteria to diagnose NIFTP, you should know, because any capsular or vascular invasion, but if the whole capsule has not been examined thoroughly, then the default diagnosis still non-invasive encapsulated FBPTC, and it is not a NIFTP. So you have to make sure to sample extensively the capsule. True papillary structures in more than 1% of tumor volume, Samoa bodies, infiltrative border, okay, should be excluded. Tumor necrosis, increased mitosis, at least 3% high power field also has to be excluded from diagnosis of NIFTP. Cell morphology characteristic of any papillary thyroid carcinoma variant include tall cell or columnar cell, whatever, or oncocytic lesion. So this is the scoring. I think in the WHO book already mentioned this. So this is based on size and membrane irregularities, chromatin characteristic. So just like our case, this is how the nuclear features looks like. So for each category, consider 1. So if the score is 2 to 3, we can diagnose it as NIFTP. Okay. So FNE samples usually hypercellular with neoplastic cells with focal nuclear features of PTC arranged in microfollicles. Nuclear features is subtle than those of conventional PTC. Nuclear inclusion, very infrequent but can be seen, or absent as compared with classical type PTC, and papilla usually absent. So in this case, it's very vague papillae. So colloid may be present, however cannot distinguish invasive encapsulated follicular variant PTC from NIFTP on cytology because we cannot evaluate the capsule. So most NIFTP cases are clustered within category of follicular neoplasm, suspicious for follicular neoplasm, atypia unknown significant, follicular lesion of unknown significant, or suspicious for malignancy or suspicious of PTC. So it is common. So kalau if the diagnosis of cytology is this, so it turns out to be NIFTP, it's not wrong. Okay. In case of cytologic features suggestive of FBPTC or NIFTP, okay, if the cytopathologists have an instinct that this is the lesion, then you need to put this comment. There's a suggestion of this comment. Although the architectural features suggest a follicular neoplasm, some nuclear features raise the possibility of an invasive FBPTC or NIFTP. Definitive distinction among these entities is not possible on the cytologic material. This is I quote from the pathology outlines. You all can see. Okay, next, case 3. 54 years old female, history of TAPSO for endometriosis in Kulim in 2015. Liver resection was done for follicular nodular hyperplasia in 2018. Now she's complained of painless neck swelling for 1 year, no other symptom. Then proceeded with FNA, then followed by left hemithyroidectomy. This is also a difficult case for us to diagnose because of its low cellularity, a lot of blood in the background with some foci of clusters of cells. Okay, on higher magnification, we can see a group of cells, follicular cells, shows a little bit some fixation artifact because of the blood. And if we can appreciate, there's a microfollicle pattern here, some nuclear overlapping, the nuclei are elongated, okay, and oval shape. Okay, on higher magnification, it looks like the cells are larger as compared with the RBC. It's very big, but we can't appreciate the nuclear details here with abundant cytoplasm. It looks atypical. Okay, this is pap smear. Very low cellularity. Okay, only some cells here seen. Very faint, faded already, this thing. Okay, on higher magnification, okay, here we can see the nuclear details better. It looks powdery, the chromatin looks powdery a little bit. The nuclei more rounded. If you can appreciate here, there is a microfollicle pattern. Okay, the reporting pathologist is very worried about this. She has an instinct. So end up with this diagnosis, atypia suspicious of PTC, because of the first, the GIMSA features just now, the cells here. Okay, there are grooving here, very big grooving and irregular nuclear membrane. So it end up with suspicious of PTC. But the resection specimens end up this. Okay, so I think everyone can know already the diagnosis. Okay, a lot of lympho aggregates everywhere. This is the thyroid follicles. It looks oncocytic, or Hertel cell-like. So on higher magnification, a lot of lymphocytic and even plasma cells, I think. Okay, infiltrates, and the cells arranged in predominantly a microfollicle pattern, and they have abundant eosinophilic cytoplasm, similar to oncocytic features. We call it as Hertel cell change. And the nucleus, if you all can appreciate, there are grooving here, nuclear grooving, and even like a groove here. All right, grooving. So it's quite prominent grooving everywhere, but we can't see inclusion here, and some prominent nucleoli, okay, and colloids. So diagnosis is lymphocytic thyroiditis or consistent with Hashimoto's disease. So patient continue follow up later. So this is difficulties that usually we encounter during cytology screening for thyroid, especially low cellularity of smears. Okay, next case, last case, case number 4, 56-year-old female, anterior neck swelling in January 2020, okay, before PKP lah. Ultrasound, well-defined hypoechoic lesion in the inferior part of the left thyroid lobe, measuring about 3.8, 2.6, and 1.5 cm. So FNA was done in February 2020. So this is the history written in the request form. No other details. Okay, so this is the FNA smears, GIMSA. Very cellular, and I think you all can appreciate papillary structures everywhere. Yeah, here, everywhere. Okay, here, another papillary structures like a finger, like projection here and there. However, there are like more prominent vessels. Okay, so this is PAP. Okay, on higher magnification, It looks papilloid. Okay. Looks papilloid structures with vessels, capillaries crossed in between the tumor cells. Higher magnification. Okay, we can see more nuclear features here. The nuclei looks elongated with some nuclear grooving. Maybe inclusion. Okay, this is pap stain. This is intranuclear pseudo inclusion, irregular nuclear membrane. The nuclei looks hyperchromatic, some nuclear enlargement, nuclear elongation. So it looks like a typical of nuclear features of PTC. So cytological diagnose at that time, malignant cell scene, PTC. Okay, this is the cell block findings. Surprisingly, I can't see any papillary, but because of the cytology, the smears features, so I more biased to the PTC. So okay, I'll explain you later. So this is the higher magnification of the cell block. The nuclei looks more rounded. The chromatins more like granular, powdery. It's not like in the smears. It's more elongated, but this one is more uniform, more rounded. Then tumor resection was done in Sungai Petani because during PKP, some of the elective surgery we transfer out to outside to other hospitals. So this is the finding. Okay, the resection specimen actually reported by pathologists in Sungai Petani, and turns out to be something else. So surgeon request slides and tissue blocks to be referred here for second opinion. So this is the slide view. As we can see here, the lesion is nodular. Okay, this is slide overall view. On higher magnification, this is the normal thyroid parenchyma, and this is the nodule. Very well circumscribed with capsule. So the features is totally different. So as you can see here, okay, this is the tumor. It doesn't look like typical follicular neoplasm features or PTC features. Okay, but in this area we can appreciate capsular invasion. Okay, I go back to the. Okay, if you can appreciate the tumor, they have this like a trabecular pattern. Sorry for the image, it's not so clear. Okay. It shows like a ribbon-like pattern with vessel cross the tumor clusters. Okay, and the nucleus of the tumor looks small, round, regular. It's totally different from the cytology features. Okay, this is on a higher magnification. The pattern is more like a ribbon, okay, with septa in between. No follicular pattern at all. Okay, and if you can see here, there is a nuclear clearing, maybe inclusion, grooving. Okay, so this is the immunostain chromogranin. So I think you all know the diagnosis. It's a parathyroid carcinoma. So later then we found out that actually what they did is a total thyroidectomy with left and right parathyroidectomy because the surgeon found out it's a parathyroid nodule. And patient actually has end-stage renal failure and known case of SLE and had history of parathyroidectomy in 2009. And patient was under close follow-up until now. The left thyroid swelling is incidentally found during follow-up. So this is the diagnosis of parathyroid carcinoma. Okay, I talk a little bit about parathyroid tumors, cytomorphological appearance, moderately to very cellular smears. Common pattern included cohesive 3D groups, disorganized sheets, papillary fragments, okay, even microfollicles, and sometimes single cells. Cells were generally small, round to oval, with mild to moderate anisokaryosis. The nuclei were hyperchromatic with coarsely granular chromatin reminiscent of the small lymphocytes. So this is what we saw, but in our case, the nuclear features is more oval, more pleomorphic and elongated. Okay, the cytoplasm was usually pale blue, finely granular with ill-defined borders. Okay, yes, we appreciate the ill-defined borders of the cytoplasm, not like typical conventional papillary CA. Okay, less common finding including cytoplasmic granulation and vacuolation. So FNA of parathyroid can be easily confused with that of the thyroid, not only because of the clinical similarity between two types of lesion, but also because of the overlapping features of the aspirated cells. So it's common to misdiagnose. Okay, I touched a little bit about the cytologic and architectural mimics of PTC because of my 3 cases. It's all about PTC. So just touch a bit about Nimicus. So PTC is the most common malignant tumor of thyroid. So usually we always tend to diagnose PTC. Its pathologic diagnosis is based on classic nuclear features, as I mentioned before. Although majority of papillary cancers can be diagnosed and classified on basis of set pathologic criteria, there exists a group of cases which benign thyroid tissue or neoplastic lesion can mimic PTC, that causing diagnostic problems. Okay, air-dried artifact of thyroid FNA specimen can lead to enlargement and marked hyperchromasia of follicular cells. This is happened to the smears. There's a lot of blood in the background. So this chromatin change may assume a circumferential shape with sharp borders and mimic intranuclear inclusion of PTC. Pseudo-clearing is more pronounced in specimen containing large amount of blood, which hinders proper fixation of smears. This can be avoided by using a thinner gauge needle, limiting number of passes, and using the concentration technique to make smears. So this is the official diagnosis of PTC in cytology. So it can be benign, it can be follicular neoplasm, it can be Hashimoto's, it can be treatment effect, it can be cyst lining cells with reactive features, it can be hyalinizing trabecular pattern, or even parathyroid neoplasm. So I have some pictures here to show some PTC mimickers in cytology. Okay, for example, in this case, this is actually a reactive or regenerative follicular cells in nodular goiter. MNG, nodular hyperplasia. There is inclusion here. This is also a nodular goiter case. So it's mimic PTC. This one, cells lining the cyst. It's more spindly, abundant cytoplasm, larger nuclei. Also can mimic nuclear features of PTC. And this is the true PTC features. Some cells looks like this with cytoplasmic vacuolation. This is maybe due to degenerative changes of the cells because of the fixation artifact. Okay, there's a lot of blood in the background. So PTC can be everything. Okay, another images. Okay, this is MNG with prominent microfollicular pattern and nuclear overlapping. Can means misdiagnosed as follicular neoplasm. This one also, but this one turns out to be follicular neoplasm. And this is follicular variant of PTC. Okay, similar to this, but it turns up to this diagnosis. This is a parathyroid adenoma. See, vague papillary structures with prominent vessels here. Okay. This is another images of oncocytic changes cells. This one is MNG with Hertel changes. This is follicular adenoma with oncocytic variant. And this is PTC, okay, with nuclear grooving here, abundant cytoplasm, ill-defined ill-defined cytoplasmic membrane. And this is the medullary CA, looks plasmacytoid with abundant granular cytoplasm. So all looks the same. So the conclusion, a little bit tips lah. Majority of PTC are straightforward to diagnose. Okay, so jangan takut. In some cases, the nuclear changes are subtle and focal. If the characteristic features of PTC is only focal, not widespread, or if sample is poorly cellular, malignant diagnosis cannot be made with certainty. So it's better to put it as atypia, suspicious. Okay, the best classified, okay, suspicious for malignancy or suspicious of PTC. So it's okay to use this term. Nuclear pallor not accompanied by other nuclear features may be due to technical staining problem. Fixation artifact due to RBC can cause pseudo-inclusion, light formation. So maybe in our cases, pseudo-inclusion is because of too much blood, okay, in the background. Cellular cohesive sheets, ribbon-like cords, okay, ribbon-like cords, occasional microacini, nuclei, round, coarsely granular, chromatin pattern, cytoplasm, moderately abundant, granular, focal nuclear polymorphism, and prominent vessels, colloid absent, we can think of parathyroid neoplasm. Okay, so just take a look at the case lah, the case that I showed you just now. I noticed that there's prominent vessels actually. It's different from the conventional PTC. So next time I know. Okay, clinical high index of suspicion for cases with end-stage renal failure and hyperparathyroidism. Usually click the parathyroid neoplasm. Okay, but if you Google, in some literature review, it is not uncommon patient with hyperparathyroidism to have incidental PTC. So it's very tricky, but just put parathyroid neoplasm in back of your mind. Okay, so these are all the references. Okay, thank you very much.